Can you hear me? Yes. Welcome to today's webinar, Lessons from Multi-Site Research, the Good, the Bad, and the Ugly. The webinar series is coordinated by the Aging Initiative, which is an R24-funded initiative that bridges the expertise and leadership of two powerhouses for research on multiple chronic conditions. Those powerhouses are the Healthcare Systems Research Network, formerly called the HMO Research Network, and the NIH-funded Claude D. Pepper Older Americans Independent Centers, or Pepper Centers. The Aging Initiative is led by Dr. Jerry Gerwitz at University of Massachusetts and Meyer Primary Care Institute, along with co-PIs Elizabeth Bayless and Jay Magdiner. My Heather Whitson. I'm faculty in the Duke University Pepper Center, and I co-lead the Aging Initiative's Dissemination Workgroup, along with Leah Hanson at HealthPartners, who you'll hear from later. So to get started with our speakers, I need to cover a few technical details. So due to the number of registrants for today's webinar, we have placed the phone lines on mute to reduce audio feedback. Unless you are logged in as a host or a panelist, your line is muted and we can't hear you. However, we welcome and encourage audience participation. To do, we'll ask that you use the QA and chat features of the webinar software. So if you're in your Cisco webinar portal and you look under the tab that says Presentation, if you to the upper right, you see an icon for chat, another icon for Q&A. If you have questions for our speakers, please use the Q&A function to submit your questions. Leah and I will be keeping an eye out for those questions under the Q&A icon. So if we have time, we'll read a few questions after each presentation, and then from approximately 1 to 1:30 Eastern Time, we'll have the entire panel of presenters available, and we'll be reading additional questions for discussion. Now, if technical or logistical questions, we ask that you submit those using the chat function. The function icon is located near the Q&A function icon. But chat function, you can choose whether you'd like your comment to be visible to all participants, or you can just send it to hosts. And to extend a huge thanks to Catherine Anzuni and Joanne Wagner and their team, who do an amazing amount of work behind the scenes to make these webinars possible. And they will be monitoring both the chat and the QA functions today to help with technical troubleshooting. So today's webinar will feature 3 presentations from speakers who will share their considerable experiences and expertise in conducting multi-site studies. At this time, I will introduce the 2 speakers for our first presentation. Thomas Gill is Professor of Medicine, Epidemiology, and Investigative Medicine, and Humana Foundation Professor of Geriatric Medicine at Yale University. He's an authority on the epidemiology and prevention of disability among older persons, and several leadership positions at Yale, including Director of the Program on Aging and Director of the Yale Pepper Center. Due to unavoidable conflict, Dr. Gill will only be with us until 12:30 Eastern Time today, but his co-presenter is Dr. David Rubin. Dr. Rubin is the Archstone Professor of Medicine and Chief of the Division of Geriatrics at UCLA, and he's Director of the UCLA Pepper Center. Dr. Rubin will be available at the end of the presentations for the discussion, the panel discussion. Darrell and Rubin are joint principal investigators of the multi-site STRIDE study. So with any further delay, we look forward to hearing their presentation about the experience with this PINE study.
Terrific. You anticipated my request. The first slide. So I'm going to give a brief bit of background and set up the study relatively quickly. Then we'll get into some of the senior issues about doing this kind of pragmatic work. As a brief background, about a third of older people fall each year, and about 20 to 30% have moderate to severe injuries that we all know: hip fractures, head trauma. Falls are the leading cause of fatal and non-fatal injuries, and fewer than 50% of people who fall actually discuss this with their primary care docs. And despite evidence that falls can be prevented by multifactorial interventions, the quality of care remains poor. Next slide, please. In 2013, an RFP came out from PCORI, who jointly sponsored with the National Institute on Aging a multi-centered pragmatic trial. Our team was fortunate enough to be selected to do this trial, and it consists of 3 joint principal investigators. Charlene at Partners is the communicating PI, Tom Gill, who you'll hear from in a few moments, and myself are also joint principal investigators. This has been a remarkably collaborative adventure with 14 Pepper Centers being involved and a data coordinating center at Yale. Next, please. The research question is whether redesigning medical practices and engaging patients to improve the quality care for falls, reduce serious falls-related injuries, and improve other outcomes. So practice redesign and engaging patients. Next slide, please. Study design is a cluster randomized parallel group superiority trial with practice stratified by healthcare systems and patients nested within practice. And all of it is pretty jargony, but what it means is that the randomization is at the practice level, not at the patient level. And that's really important, and talk a little bit later about how that affects the study. A very large clinical trial, 6,000 participants who are being recruited across 10 sites. On average, each of the sites has several intervention practices and several control practices. And from these practices, about 75 participants are going to be recruited over 18 months. Overall study duration is 5 years. We are now at about the 18-month point, a little past the 18-month point. Next, please. These are clinical trial sites, and I'd like to just note that for the part, although not exclusively, they are either care systems, research network sites, or Pepper Center sites. They're widely diverse across the country. There's a little bit of a cluster in the Northeast, but certainly geographic, rural, urban, and ethnic diversity through this. Slide, please. Who are the patients? They are community-dwelling older persons. That includes people who both live home or at assisted living facilities, as long as they can come in to see their healthcare providers. Those who are based in nursing homes or living in nursing homes are not eligible. Have to be 75 years of age or older. This was chosen because that's when the rate of injurious falls tends to skyrocket. And they have to meet one of 3 criteria for being a risk factor for injurious falls. These include they've fallen and hurt themselves during the past year. They've full falls defined as 2 or more falls in the past year, or they express fear of falling because of balance or gait problems. Next slide. The engine is really categorized into 2 ways of thinking. The first are the care processes. Are the what, and these are identifying risk. These have identified literature-based, evidence-based interventions that reduce the risk of falling or falls-related injuries, and we have a series of experts who operationalize these into algorithms. We noted, and this is important with a pragmatic trial, all these are standard of care. We're not subjecting patients to new research approaches. These are standard of care. The second big component of the intervention is the how, and this is really taken from the playbook of the chronic care model. It's really systematic implementation into healthcare setting using practice redesign. In this case, we're using co-management with registered nurses who are the falls care manager. I'll tell you in just a moment about what they do. They have decision support. These are the algorithms that I mentioned previously that tell them what to do and in terms of how to address risk factors. And then we are implementing a software system to facilitate this, to make sure that the intervention is delivered correctly and also as expediently as possible. The third component to this, second component to this, is the patient and caregiver engagement and activation. Here we spend a lot of time with a fall care manager and patients, helping them become engaged, motivated, and active partners. And finally, linkage to community-based resources, in particular community-based exercise programs that are an important component of the intervention. Next slide. All care managers do. They work with patients and caregivers. This is a collaborative effort. They assess the risk of falling. With the patients and caregivers, they create a fall risk reduction care plan. They implement the plan. This includes coordinating multiple providers. Every visit, they spend time promoting self-management, engaging the patients, identifying obstacles. They monitor the patient's progress, and they help the patient overcome obstacles. And as I mentioned, a tremendous amount of motivational interviewing is involved. Next slide. The 7 risk factors we're addressing are high-risk medications. These include not only those that predispose to falls, but also excessive alcohol use, postural hypotension, visual impairment, foot problems and footwear, osteoporosis, although not a falls risk factor, it is a risk factor for serious falls-related injuries, home safety, and then a very important physical component of leg strength, mobility, and balance. He identify what risk factors, identify the community assets, the resources, and help patients by motivational interviewing to identify risk factors that they want to work on and how to do so. Next slide. Turn it over to Tom here, and he's going to go over the next few slides.
Thank you. The primary outcome for the trial is operationalized as fall injuries leading medical attention, and include vertebral fractures, joint dislocations, head injuries, lacerations, or other major sequelae of falls. There are additional outcomes that include all falls regardless of injury, and then a set of well-being measures that were part of the initial RFA, including physical function and disability, anxiety and depression, and falls efficacy. Slide shows the kind of flow of patients through the intervention component study, and first they have to be screened, and screening I'll tell you more about in a minute, but it's largely done centrally, and then once they're enrolled in the study, they have risk assessment that Dave just explained, and includes management, and then the intervention itself, and then there are follow-up, and the follow-up both in terms of assessing the outcomes and also the continued follow-up by the fall care manager. So here are some of the early challenges and barriers that we've been confronting and trying to address. And they include in screening and recruitment, standardizing the intervention, of the intervention and the practices, and a few others. Slide. Screening, as Dave indicated, I mean, this is a very large trial in which we're enrolling 6,000 participants, and so you might anticipate we're going to be screening a much larger number of participants that reside across these different healthcare systems. In year 1, we conducted a pilot because there were 2 proposed strategies for screening. a central screening strategy that was conducted primarily through mail surveys, trying to identify participants who screen positive on one of those three fall risk factor items that were mentioned earlier. And then clinic-based strategy in which when persons come in to see their primary doc, they're screened, with their vital signs with those three questions. And the pilot indicated that both strategies were effective, but we decided that it would be more efficient and if we went with a central strategy, which is conducted out of Yale. But one of the 10 sites wanted to maintain a clinic-based strategy. They had, health systems that would have difficulty providing lists of their patients to Yale for the mailing. So we decided that we would make an exception, and one of the 10 sites is doing clinic-based screening, and it's a site that's quite savvy on the IT side, and so our experience to date has been quite successful with this kind of hybrid two-mode approach. And the advantage here is that if and when we demonstrate the effectiveness of the intervention, there'll be two ways in which patients within the healthcare systems could be screened. And you can make arguments that either a population-based approach, which is really central, or more of a patient-oriented approach, clinic-based screening. In terms of some of the challenges, more recently in central screening, it was not all the sites provided the lists of age-eligible patients in a timely way. So there were some delays, and that's set us back in terms of our recruitment efforts. Some of the lists that we received had errors in them, duplicates, and that required some work back and forth between Yale and the IT groups at a few of the sites. And there's just varying levels of IT expertise at sites, or at least in terms of personnel that we had access to. And for the clinic-based screening, we're dealing with challenges of what to do with patients who are frequent flyers, who are coming in to see their primary doc, every other week or every month, and we manage, do we screen them each and every time, and we track when they were last screened, and if they were screened and then subsequently decided that they didn't want to participate in the trial, do they continue to get rescreened, and we don't want to call them again to be recruited. So we're working some of those challenges, but in the site that's doing clinic-based screening has a very strong IT group, and we've been able to address the challenges that we've been confronting and trying to operate in a way that's efficient. Next slide. So recruitment, after persons have been screened by one of those two mechanisms, recruitment is done centrally across all sites at Yale, and this was just the most efficient approach rather than setting up expensive system-based recruitment strategies across 10 sites. It's all done under one roof at Yale. But we do, as I mentioned, need to close the loop for clinic-based screening so patients who decline to participate are not subsequently recruited. And as indicated, from a statistical perspective, the most efficient way recruitment would be to have 75 participants across each of the 80 practices. But these practices are vary in size, quite substantially from as small as 250 age-eligible patients to larger practices that are up to 1,500 or even 2,000 patients. So we're likely going to have to make some compromises because we'll quickly exceed the capacity for the smaller practices and have a repository of potential patients that we can recruit from larger practices, but it's going to be trade-offs because if there's a great disparity in the number of participants across the practices, that will have an adverse consequence on the sample size. We need a greater number than 6,000. Next slide. I'll turn it back to Dave, who will complete this segment. Dave, you're on mute.
The next challenge has been standardizing the intervention. Here it started from the very beginning with recruiting RN falls care managers. Think about this as being a research overlay over practice, and these are positions that are generally been clinical nurses, and here have to, in some of the cases, relinquish positions that are very, very stable for a position that would last about 2.5 years at maximum. And it was even worse because we didn't know at the beginning whether that second phase was even going to happen at the pilot year. So hats off to all the nurses who were recruited. There a couple of sites had false starts. You realize that there just has to be some startup problems with recruitment. Second, it was to standardize the intervention, and these were to actually develop the clinical protocols based on the literature. For each of the group risk factors, we developed a small working group with a lead who would come with protocols and algorithms. And as much as there is fact out there, there is a lot of opinion out there, and some very, I wouldn't say heated discussions, but intense discussions about different protocols and what should be, how this should be formulated so that a nurse can do this without having to invoke additional resources. Falls care managers, once again, to try to standardize things, we had to have a uniform training process, and we decided that in addition to some in-person training, a lot of telephone training, we would create videos basically that would be allowed for, that would permit online training. And we partnered with the Institute for Johns Hopkins Nursing to create these enduring materials. E-content experts took responsibility for developing content, and then a working group helped with that. And these look excellent. But the thing that we recognize also that this is an evolving science, and that these are going to have to be continually updated. Identify community-based resources for exercise. One of the things we learned very early on is you've seen community-based resource exercise. You've seen one community-based resource for exercise. And these vary tremendously, some of which are probably very valuable. Others are equivalent to snake oil. And so we had to go through a vetting process to make sure that community-based resources that we are going to refer, the falls care managers are going to refer to, are actually valid and achieve the purposes of this component. That evidence-based prevention methods by home health and outpatient physical therapy are the ones that are being used. We're relying a lot on the Otago program, but it turns out that when you order gait balance and strength training from a physical therapist, particularly in home health, you can be getting a lot of very different things. So we engage in both some training sessions and also site visits to ensure that, in fact, that the intervention that is being delivered by the physical therapist was standardized and correct. And, maintaining fidelity. You can get up and running and working pretty well, but people change, programs change, health systems change, and in fact, this is not a river. This is not a pond. This is basically a river, and it changes all the time and needs to be constantly updated. Next slide, please. Another challenge we've had to face, and this relates to the pragmatic nature of the trial, is really integrating these into practices. is not like your typical drug study where you would just recruit people and it would have its own universe in terms of the research. In fact, these falls care managers are integrated in the practice. They're using the electronic health record, et cetera. And this is challenging. This is challenging in many respects. A lot of it are the logistics, just identifying space for where falls care managers are going to see patients in each of the offices has been somewhat challenging. Most of these offices are very busy and don't have a lot of extra space. For providing support, whether those be patient services representative support or just administrative support, has also been a challenge, and different trial sites have had to cope with this in different ways. Getting with primary care physicians, as this trial has evolved, more and more systems are on electronic health records where the primary kind of communication is through the electronic health record, through the in-basket. But in fact, we've had to evolve these kinds of things to accommodate preferences of individual trial sites and some individual preferences of the docs. Implementing this in the electronic health record, here we've had to create templates so that, in fact, there's kind of a uniform feel and sense to what a STRIDE note would look like. On the other hand, we have to recognize that there's a local culture of what notes look like, and we have to respect that culture. Finally, identifying and using resources within the healthcare system so that there are, say, for example, orthostatic hypotension that is identified and may need further evaluation. There may be a go-to person or go-to clinic that is available for that, but each health system has a unique set of these, and that's been an issue for the care managers and the study coordinators to identify. Next slide. Other. I think these are things that we perhaps didn't expect as much, but came back to bite us in many ways. The first is the overall organizational complexity. You're dealing with 10 healthcare systems. You're dealing with 3 institutions where the PIs are located. You have a data coordinating center that's a different institution than the central project management. And you've got all the pepper centers involved in some way, shape, or form, although some centers just have a representative on a committee. And very soon this gets very, very complicated. We have set up something called Box, which allows a kind of a central of finding out what's going on at any time, and websites, but even those fail sometimes in terms of communication. Another issue that we didn't anticipate is the joint sponsorship, and that's had some pros and some cons to it. Basically, do we have to be on the page with the sponsor? We have to be on the same page with 2 sponsors. And those 2 sponsors sometimes communicate very well with each other, and sometimes are very aligned with each other, sometimes not so much. Once again, it adds a whole nother level of complexity, a whole nother level of communication challenges, and making sure that not only everybody is on board in terms of both of the sponsors, but that their objectives are the same. The initial proposal was for $30 million. It was a study that was cut. Typical NIA sponsorship, you see about 18 to 20% cut. With Missouri, that's not so much the case, and we were given full funding. And about midway through the first year, I realized that it wasn't enough. It certainly wasn't enough. And you think $30 million, 6,000 patients, but in fact, when you compare it to a number of other studies that have been of this magnitude, it is budgeted much less. We're always scrambling to try to save money for the study, and there are many things that we would particularly the clinical trial sites that we would like to put more money into, but in fact, we're in an era of finite resources with this study. So I'm going to stop, and I don't know whether you want questions now or we're going to just hold them until the end of the presentation.
think, unless Leah disagrees, I think maybe we can move on unless there are particular questions for Tom, although actually Tom may have already needed to depart.
I'm scared. I'll be leaving shortly. But Dave could probably cover any relevant stride-related questions if needed later.
Okay. In that case, I'll just, maybe we just, yeah, so I do have a submitted question if you all can respond to this, and then we'll prepare to move forward. The question was submitted is, what did you do particularly for stakeholder engagement and to get each site on board?
Well, just to answer that quickly, there's kind of two questions. Stakeholder engagement really included more than just the clinical trial sites. Included patients, it included community-based partners, it included home health agencies, and we established a structure, a separate parallel structure that is the patient and stakeholder committee, and it has two levels. One is a national committee, and the second is local. So there's been a tremendous amount of effort put into bringing stakeholders on board. To get the sites on board early on, and a lot of the spade work was done actually even before the proposal was submitted, was a lot of one-on-one conversation and also bringing them into the planning process. And I think that was really important. I think if we had it to do over again, we would have even done more of that.
We do have one more specific question for the STRIDE study, if you will, and it is, were any incentives provided to the participants, like a certificate of participation, a mug, recognition of participation, and how is that evaluated?
So that is still in process. We have a whole kind of incentives. A lot of these relate to retention, et cetera. So there's a number of certificates, et cetera, that and the practices have certificates, are going to have certificates. It is still a work in progress, and it has not been evaluated yet.
Okay, I think so. We do appreciate the questions coming in. Please continue to submit your questions. Use the Q&A function, and we'll move on to the next presentation, but Dr. Rubin and the other two speakers will be available after 1 o'clock Eastern Time for further discussion, so hopefully we'll get to all the questions at that time. And I'll hand to Leah now.
Thank you, Heather. It's a pleasure to introduce Dr. Eric Larson for our next presentation in this webinar. Dr. Eric Larson is Vice President for Research at Group and Executive Director of the Group Health Research Institute. He spans a range of general medicine topics and is focused on aging and dementia, including a long-running study of aging and cognitive changes set up in Health Cooperative in Seattle. He served as chair of the OTA-DHHS Advisory Panel on Alzheimer's disease and related disorders, and was of the American College of Physicians Board of Regents in 2004 to 2005. He's an elected to the National Academy of Medicine. In his presentation for this webinar, he will draw on experiences in multi-site trials and projects. This is the NIH Common Fund, pragmatic trials, clinical trials, healthcare systems interaction projects. Larson.
And thanks to all of you who are attending. And it's a pleasure to follow on the STRIDE study, because I think you'll hear some summative themes in my presentation, which, as Leah said, is probably based on a combination of my experience doing trials in persons with multiple chronic conditions, but more recently this great job I've had as a co-PI of the Common Fund Pragmatic Clinical Trials Cultory. And our group has been charged with trying to create general knowledge based on the experience the trialists who are doing these pragmatic trials. And if I could go to the next slide. I guess I'm going to do the slides myself then, okay? Let's see if I can do that. We used this definition of pragmatic trials, this notion that you integrate the research we do not in systems or outside where care occurs, but actually in the setting of everyday practice. The idea is that these are addressing issues relevant to patients, clinicians, and delivery system leaders, and more importantly, hopefully, it will speed up the process of translating what we learn from research into everyday practice. And you'll see at the bottom of this slide and some of the other slides that what I'm going to present today has been published. The paper recently came out in a journal called Healthcare, and this is the result of the work that we did as a support group for the fund collaboratory, but also involving all trialists that are doing these trials. And trying to advance the slides here. So this slide, I may have done 2 slides. Let me just check. No, okay, good. So talk about some of the lessons learned that I'm going to be covering. And this is a lot of what I'm going to say you'll find is common sense, but unfortunately not that common in the kind of research that we do, especially coming from places which are not delivery systems. So you have to start the pragmatic trial that's embedded in a delivery system with a partnership. And I think you heard from David and Tom that it's not automatic that you have a partnership. You have to determine first off, are people able to actually participate on the system's capacity to do work and the kind of work. And at the end of the day, you like to see that partnership end up with a result that people are going to say, yeah, we've made an advance here and we can improve care. And along the way, if you're successful in establishing this partnership between a researcher and a system, I can't promise it, but I can virtually make a strong prediction that this is the basis of long-term scientific relationships that will be ongoing. And I think that's what we experienced here at Group Health, where the Research Institute tries very hard to put with our current system, and I think many other embedded research institutes that are successful do this. Here at the bottom, the reference to a paper that Karen Johnson wrote in the British Medical Journal in 2014, which is a nice sort of guide. And again, much of what I say is in this paper. This model that Karen and the team developed, and it to state the fact that there is a partnership, and that's where it all starts. And ideally, that partnership comes from real-world challenges. And I think David and Tom pointed out that there's a real challenge in trying to prevent falls. We know a lot about the information, but about works, but it's not really been applied in any way that's resulted in a real-world improvement or the real-world challenge. And so you go through this cycle of defining the question that you want to ask, and again, in partnership with the people you're going to be working with, who are the doctors and the nurses and the occupational therapists and whomever, you assess the feasibility. And what we've learned that I think David is HR is just one EHR, and a lot of people think they have the feasibility to use the EHR, and in fact, when you get to the rubber the road, it may not be there. You would just as needed, and then keep going through the cycle of involving the stakeholders in design and implementing the workflow. And at the end of the day, these cycles, hopefully you come out of them with the end result of improved care. The questions that should be considered as you begin to plan a trial, and this may might have come up in the question about incentives. It's not just incentives for participants who are your subjects, but it's really incentives for participants who are your partners. So what motivate a clinic or a hospital or a healthcare organization to participate in a research study? You have to remember that the system has its main job to have the lights on and the doors open and to meet the needs of the patients they're caring for, or in some cases whole populations that they're caring for. Why would it be attractive to a clinic or a hospital or a care organization? And try to answer that question in the positive. Can a pragmatic intervention be designed to fit the workflow within which it will be administered? If you try to go to a partner in a project, say this is the way it's going to be, time to fish or cut bait, it's not going to work. You have to figure out what the workflow of the clinic is, and then use your common sense and partnership to figure out how you can do a pragmatic intervention alongside all the other things that people are expected to do in their everyday work. And what is the feature of the intervention and the trial that will to a sustainable, translatable result? I think this is an area where we still don't really know as much as we'd like to. Why some trials don't actually translate, because there's something about it that is a non-starter for a system. So you can demonstrate a result, but you can't necessarily expect it to spread. So one of the areas that we're working on in the collaborative is to try to better understand what are the traits of a trial that's going to lead to a good result in terms of translatable result. One of the papers that we wrote called Trials Without Tribulations, Minimizing the Burden of Pragmatic Research on Healthcare Systems, was on case studies, just like you heard, a case study from the STRIDE trial, where we interviewed the researchers, physicians, and delivery system lead and came up with these lessons. And this is, I think, some of the take-home messages for my presentation. I said earlier, but I'll say it again, you need to have a partnership. And if you've had a previous collaboration, you've got some capital that you can draw off on. But in general, you start with identifying the research question. Make sure, if possible, that it's a research topic that's a high priority for clinicians and researchers, and that the researchers have to respect the providers who interact with the patients by not scheduling study-related patient visits during the busiest clinical times. It can be a deal that is really hard to navigate, and I think you heard a little bit about that from David and Tom in their presentation. But the idea that somehow the clinics will just kowtow to a reader, especially if they're not part of the clinical system, is probably a non-starter for most successful partnerships. Do a pilot project. I can't emphasize enough the need to the pilot project, and I think you heard a little bit about that in the STRIDE project, but you will almost certainly find that there are things that don't work the way you plan them to work. You find that you may have misestimated your cost, and you can learn ways to improve the design of the original study through a pilot. In one of our studies, it's a SARM study, one of the aims was simply eliminated. In other studies, the pilot was able to realize that one site was just not capable of participating. And it's easier and better to find that out before you get down the line in the second phase of the real study itself. So the core, and I think many projects now are requiring that to get to the full trial, you have to have successfully completed a pilot. Some of the pilot questions are just what you heard about in the presentation. Are you going to have the numbers? Are the data going to be available? Can you get the data from all sites? Variation is there? You expect there's going to be variation in multi-site trials, and how we're going to handle that. And the oversight issue has been a huge problem for multi-site trials, and you can see the new Common Fund, Common Core standards that is looking very carefully at ways to try to reduce the delays that have occurred because of oversight in different systems and the variation there. And then the bottom of critical question is, how is this going to help your partner? How is it going to help the people beyond you're writing a paper, but more importantly, are going to help people have better health and well-being? Take of the existing infrastructure. If you have an on-quality improvement program, pay attention to it. Listen to the people who are already doing that kind of work. Make sure that you're partnering with them. You know their workflow, understand how they can help you out, and in-person visits is critical to manage a study that's complicated by email and telephone calls is probably not the greatest idea. Ideally, you become have in-person contacts and relationship with all your sites. Minimum impact on clinical workflow. The idea would be to not overdo the research. A pragmatic trial is not an explanatory trial. You're really trying to answer a single question. You may not be able to understand the mechanism or the details of how the effect occurred, but use what's available to minimize burden on and also burden on the subjects, and use the data that are already available in any systems. And this last bullet on this slide is really important. Be prepared to compromise. All collaboratory studies that have been successful have compromised from their original design based on what they learned when they actually go into the field. Be as automated as possible. We have a tremendous upscale in our ability to collect data in non-invasive, more efficient ways. So use your IT staff at each site and try to automate the intervention if at all possible. That's clearly going to be the wave of the future, I think, in this kind of research. But also try to use the system to collect as much data automatically as possible from the local site. But be prepared to experience that the IT staff has more work to do than they have resources. So people will be reluctant to take on huge change in an IT system just because you're doing a research project. So again, it's a partnership. This is a phrase from John Steiner, who leads the Kaiser Group in Denver. Research are the tail, not the dog. So we all are aiming to improve healthcare, but the purpose of the system is not to do research, but to provide good healthcare. So you can get a strong commitment to research from a health system, and I think most people at least talk about a strong commitment. But you have to understand that the first priority of a healthcare system is not to do research if it's sort of patient-centered healthcare system, and you just have to accept that and keep that in mind. And so in three bullet points, I think this is my last slide, are start with a partnership and be flexible throughout, and except you will have to adjust the study design if you're really doing a pragmatic trial that's embedded in a healthcare system. Tailor the pragmatic trial to the unique culture and workflows of each delivery system, and expect that they will be different. That doesn't have to tailor an intervention of it's very true, but you have to tailor the way the intervention is worked in a system, especially if the systems are as different as you can expect. And then you've seen one pragmatic trial, you've seen one pragmatic trial. You just have to expect that you're going to unexpected event that you're going to deal with during the trial. It's really interesting that even in a place like group health, where we're intimately familiar with the way things are operating, always getting unexpected changes that we don't know about until they happen. So this is where you kind of have to be on the ready, and especially expect the unexpected if you're relying on electronic data collection, because data systems can change in a minute, and something you thought you would be able to do can suddenly just disappear, and that means you have to be very engaged with the system and that you're working with, and know what those changes are. And I think that last slide, and be happy to wait for questions so he can have her presentation, or I take some now.
Thank you so much for your presentation. I think we'll do two quick questions that have been submitted. On the slide you talked about the case for conducting a pilot trial. Is it necessary to pick a random site for the pilot trial, or can you pick a site because you have established some collaboration with that clinic and have a relationship there in the past?
I think it's not. It would be better not to pick a random site unless you were very familiar with all the sites that you could choose from. I think you really want to pick a site that you think is capable of doing the trial, and that you are pretty confident you can develop a partnership with. The partnership, it's not quite like a marriage, but it's close to a relationship that you want to see succeed, because you're both committed to the goals. So the site is, I think, a important step, and making it in such a way that you're confident that at the end of the day you'll have a relationship that, in the case of most trials, is going to last for 5 or even 10 years. So it's very important, and a good question. Thanks for the question.
How are health systems benefiting from the qualitative benefits of studies, practice change, and quality improvement? Are there parameters that health systems are responding to, such as community reports, annual reports, CMS requirements, or quality?
I don't know that I have a good answer to that question. I think that there has been a bit of a rush, if you will, from health systems seeing the collaboratory and some of the CMMI products to establish these partners, and they're from small practices. Like there's a Healthy ABC study involving 50 small practices in the Northwest. And that's very pragmatic around reducing cardiovascular risk to the projects that you're seeing. But I really think what we know is that the systems are to these funding changes, opportunities. What we really don't know yet is how this is going to play out. And I think it's one of those stay tuned. And again, the purpose of our group is to find what generalizable knowledge there might be from all this. And I'm guessing that in the 3 to 5 years, I'll be able to answer that question.
A quick follow-up question to the pilot site. NIH reviewers question the feasibility to scale up your intervention in a larger trial if you don't pick a random site. Is an issue?
Well, if anybody can predict what NIH reviewers are going to say, they're a lot more smart. They're not smarter than I am. I think that the experience with reviewing pragmatic trials has been pretty good at NIH, and I think same with PRI, but in both of those institutes, it's that the reviews are also somewhat unpredictable, and I think that one of the things that we're trying to learn in our work is what are the critical features that make a pragmatic trial likely to be a success? Because even though we've been doing pragmatic trials for a long time, the criteria for pragmatic trials are not the same as they are for explanatory trials. And I think if NIH may be more to explanatory trials, and the whole field is geared more to explanatory trials. So I think over time we'll have a better idea of what features make a pragmatic trial more successful or more likely to be successful, and hopefully that will then be part of the review. I do not think that a viewer would question that chose not to randomly pick a pilot site.
Thank you so much, Dr. Larson, for your great presentation. We'll be moving to our third presentation in this webinar. It's a pleasure to introduce Dr. Rebecca Silliman. She is a geriatrician and epidemiologist at Boston University, who's been conducting multi-site breast cancer outcomes research over the past 30 years, including a 10-year study in collaboration with HCSRN investigators. She previously directed the RCDC for the Boston Pepper Center and coached the pilot program for the Aging Initiative. Dr. Silliman, thank you.
You've heard about the scientific and pragmatic aspects of multi-site studies is to talk about the intersection of multi-studies and team science. And that's why the roadmap of my presentation, which is to provide some definitions of multi-site studies versus team science, to give you a personal history of multi-site science research that I conducted over 30 years or so as principal investigator, refine what went wrong as well as what went right in those studies, and to give you some suggestions to how you avoid making some of the mistakes that I made. This is the punchline for my presentation. So it's titled "Scientists Need to Learn How People Operate." That's really quite true. This is a kind of a chaotic orchestra with the conductor sitting on his podium, looking at score, trying to figure out what went wrong. The cartoon from nature and was particularly amusing to me as a musician who is in many orchestral groups. But the point is, if the conductor doesn't know how to lead, all's lost. The same is true for scientific leaders. And then my focus is going to be on the interpersonal aspects of multi-site studies and team science as key aspects of leadership. Next slide. So the punchline, let's begin with some definitions so that we're all on the same page. Science is defined as a collaborative and often cross-disciplinary approach to scientific inquiry that draws researchers who otherwise work independently in cooperative groups organized around a shared interest. Next slide. I'm interested in a couple of the phases or in the definition of team science, specifically team and collaborate. So Dr. Webster to see what he might have to say about these terms. And finds team as a group together, or secondly, two or more draft animals harnessed to a farm implement. I think the point is that team is greater than the sum of its parts and works most effectively if everyone is pulling in the same direction. With respect to collaborate, he defined as to work with others to co-opt an enemy that has invaded one country. Now, I have these slides with some of my colleagues. I actually thought that the second definition here about cooperating with an enemy was pretty funny and quite reflective of what team cohesion it can be all about. But others were really think that there's a very good definition, feeling that enemy to an anachronistic term. If you substitute other for enemy and other as somewhat different discipline, culture, institution, or generation, and then to that has joined one's team or that has invaded one's country, you get a definition that states to with an other who has joined one's team. And I think this conveys the concept of collaboration, basically to play a sandbox together. Next slide. So distillate of these definitions reflect the concepts of team science, which are shared vision and trust. At this point, that in general, all multi-site studies reflect team science, but not team science need be multi-site. In fact, much good team science goes on within various institutions. So with that in mind, I'd like to turn to my own history for the next slide and tell you about future observational studies of breast care in older women that I've conducted over my career. So the first was in response to an RFA and my first R01. The project was also later funded by a Department of Defense grant. Boston, and in academic and community hospital settings with oncologists as site PIs. Because of the nature of these surgeons, because they're very busy surgeons, the data work with my research staff under my supervision, working with staff at the site. Investigators were monitors and were hands-off. It worked quite well because I was in charge and had everybody doing what needed to be done, and I didn't have other investigators getting in my way. Study, which of course had to be run better, involved more, was by my second, third, and fourth R1s. With sites in Carolina, Rhode Island, California, Minnesota. I chose the site PIs because of their stature in the field, the fact I had either collaborated with them or they collaborated with other members of my local team. And they were very experienced, and their contributions to the project were actually the science as strong as possible to me. Actually, to be willing to be co-opted by me, so that because they were members of my research team, they couldn't respond to the same program announcement or ultimately the same RFA because they were my team and therefore couldn't compete with me. Now, these studies were limited by convenient samples, the fact that we chose a person enrollment strategy, which not only took a long time and therefore led to fairly limited sample sizes of about 300 in each study, but were associated with a lot of selection bias, particularly in relation to education and age. And longitudinal follow-up was, of course, all selected, and we were relying on self-reports for longitudinal data. So opportunity presented itself to improve science using data, as Eric mentioned, complemented by medical record data. We used numerical cohort design that resulted in efficient data collection over 15 years of over 1,800 women. study made in heaven. However, the other characteristics of the study involved the investigative team, which was a diverse team chosen by the Research Network leadership, involving mid-career investigators from many different research cultures whose sets and needs were not new to me, or their research settings and capabilities, and I didn't know any of them. More graphic science around the United States, and of course, before we funded, there was no money. During this year of means through both grant planning and so Project Startup, we did all of our business by telephone. Slide. So I conveyed that the first two models of studies worked really well because I really lead a team, or the team members were fair in their relationships to me. Third study things were quite different, and I wanted to talk about some of the things that are wrong, because I think they can be helpful to you and be addressed when I how to avoid mistakes. So that's wrong. Relate my underappreciation of what it takes to build trust because of distrust. It's a lot about building relationships, and I would just on that to the term trust. And he also talked about the relationships between academics and in my particular case, it was the at Boston University versus highlight researchers at non-academic research settings. I also appreciated their creation of collaborations with academics. I created the partnerships among these team members, both positive and negative, allowed coordinations within the group, and some meeting up on one another on occasion. And the importance of a written publications policy handing dispersed first authorships over a collection of papers. And by this I mean sure that as many people as wish to be first authors were able to be first authors, or papers, which of course is needed for a successful continuation application. But balancing those two, I stepped my initially. When she did go right, there was extensive mentoring within the team, and example, not only by me but by others. We engaged a number of early career investigators who also became first author of papers once was funded by a supplement to model consistent behavior the course of the project, and I think was reasonably successful with that. And I continued and supported by everybody else, did focus on quality science with this first authorship. I published 22 papers on that project, of which I think are stated in the field. Through the continued building of trust, we're successful in publishing those papers, and also with obtaining continuation to the initial grant. Next, taking what I learned from, particularly from this last project, here are my suggestions for how to avoid the mistakes that I made. Recognizing that you all make your own mistakes, that it will be important to recover and as soon as possible and as positively as possible. This published here is available online, and I think it's excellent. Read it several times before you get started. Know your own strengths and weaknesses, and possible choose your team members. It's possible for their strengths, weaknesses, and needs. There are always budget constraints, but to the extent possible, try in person early often. I think the mistake that we made in not getting everyone together in a room to meet each other as early as we might have. It's in that you can develop a shared vision for the research values, which I think the two most important are integrity and accountability. Next slide. To help you avoid mistakes. Methods and procedures explicit, roles and expectations. I think strategies like Dropbox allow greater transparency in a repository for all written documents, so all can access them when they wish. And this is particularly important because we all have short-term memory problems. We're busy people and we forget things. So being able to point in an easily accessible place where something up and say, oh, yes, that's what we decided, or oh, that's what that your proposal is about, or whatever. Listen and listen some more. Communicate some more. Trust is fragile and will happen. Resolve that conflict via email, or that trust that you developed will be torpedoed very quickly. Everybody is pulling in the same direction. The team wins. Next slide. Science will get you funded, but poor interpersonal relationships will keep so and invest in both things. The orca follow you and sound heavenly. Comment, this is from a colleague of mine. Our colleague gets better than us older folks. So their collaboration strategies inclusive social media. And proud of you on our webinar who are our junior colleagues will take the lead and do a much better job than some of us in conducting multi-site studies and team science. Thank you very much.
Dr. Silliman, that was fantastic, and thank you. I just want to thank all of our series of presenters who all did an incredible job and gave us lots to think about. We do have several questions that have come in, so if it's okay, I'm going to just jump right into those. We had one question that was submitted to the webinar by Bill Hazard, and Becky touched on issues related to publication and also the role that junior and mid-career level faculty often play in these very large team science multi-site endeavors. So Bill's question was, how do you recognize the contributions of authors to these multi-site big science research undertakings, and how can you identify future research stars, like those for whom you might want to give protected, mentored career development time, among the many authors other than the first or last show up on the paper?
The short answer is with great difficulty. You know, I think that's one of the challenges that Appointments and Promotions Committee are having is how to give appropriate recognition to PAC that's in the middle. Belief is that as a principal investigator or as principal investigators, you know, most have made our careers. And one of the things that I did in our continuation application, or a continuation part of our project, is I said, you know, I don't need to be senior author on any of these papers. So one of the things that allowed for is for sort of mid-career people to in the senior author position. It just opened up more senior and first author positions. And I think intentional about giving junior opportunities, particularly on the first author end, and more mid-career people for senior author positions, was really important. And so I guess the bottom line is be generous. We still, for worse, use these metrics and until we figure out a better way, and I don't have the answers for that, I think we just need to be very intentional about making sure that it gets spread as generously as possible.
I'm going to go back and revisit some questions that were related to STRIDE that have been submitted. So, Ruben, if you can answer these. So one in particular was thinking of the limitations, funding, complex infrastructure, communication, funders. Can you tell us what, if anything, you would have done differently in setting up the study?
You'll always think about what could have been better and what. And during the time that you're planning these things, and they're always, you're never sure whether you're going to get them or, you know, what the budget's going to be, et cetera. I think I would have had more participation among by the clinical trial sites in the planning. I think some of the most challenging issues have been implementation. And this harkens back to a lot of what Eric had to say as well, is getting these partners on board and contributing as much as possible from the get-go. So the ownership is not necessarily by the research team, that the ownership is really by all partners.
Thank you. Other question specifically related to STRIDE was home safety was listed as part of the initial screening process. Can you talk about standardizing that across the sites? Was it and how was it standardized across the sites, and does that also fit into the intervention component? Was it part of the screening?
So there's two components. One is the home safety. We're using CDC developed home safety checklist by people who might have home safety as a risk factor. So that's the risk factor identification, and then there's a whole algorithm for what to do in that case. It turns out we have to work within the existing healthcare reimbursement system, so that there are certain criteria that has to be met if somebody is going to get a home safety evaluation or a home inspection, and it's covered by Medicare. It's not just that you have a bad situation, you have to have a bad situation and some additional risk factors. So there's, first of all, the identification, then the determination of what is the most appropriate intervention, and also how this can get paid for under the current system.
Oh, thank you. I'm going to move now to a question that was submitted for Dr. Larson. You spoke about automated interventions, and I believe spoke of them as sort of a wave of the future. One of the participants asked if you could provide some explanation and examples about what's meant by automated interventions.
Sure. That's a good question, and I think I'll bet a lot of the people listening can think things on their own here. But once I think a really cool study is LIAR. It's called LIAR. Everyone should want to pronounce it. This is a study that is led by Jerry Jarvik and is conducted in, I think, 4 sites, a group in Northern California and a couple other sites. And what he has done is, using a cluster randomized design, taken all the back imaging reports that are generated and inserted a box which states something to the effect that without back pain have such a frequency of disc narrowing, degenerative disease, osteophytes, and so on and so forth. And he basically intervened to see if giving clinicians the base rates of, quote, findings in people without back pain, how they interpret the results of pathology report. And that, he has to work very closely with the neurologist to make sure everything is going to work in each systems that are involved. But it's actually an electronic intervention that involves just information in a radiology report. That's an example that comes to mind. But more people are thinking about efforts to help people stop smoking that are web-based now, and I think what we're seeing is let's mobilize both the information we exchange within the healthcare system between clinicians to active intervention, and maybe even more powerful is working directly with patients use electronic means of communicating. And in older people, the frequency which people use the internet is very high, and it's actually highest for people with multiple chronic conditions. So at Group Way, the highest users of internet-based medication are the people that have the most chronic conditions. Well, of course, those are the people that need the most health care. So in working with populations and people with multiple chronic conditions, I think the internet and just electronic interventions are the wave of the future.
Great, thank you. And I believe I have at this time one more submitted question, and it's about the patient refusal rates. I think this question was submitted in relation to some of the discussion around the STRIDE but maybe if I could ask all of you to just touch on, do you feel like rates of patient refusal to be higher or lower, or issues there with large multi-site studies that are looking for 6,000 patients and that sort of size order, and also what you do when you have differences in terms of enrollment and recruitment success across sites?
So first stab at that, and I think I was just interested looking over our recruitment rates, and it's about 7 to 10% of people who are eligible are getting recruited. Not huge. I personally think that that recruitment rates in general are more difficult now. They're also more difficult if it's a centralized recruitment process. But I think that the problem is that just as we face in our own lives, our patients' lives as well, is that we're faced with information overload. And there's just so much going on, so much solicitation, and solicitation for a trial is just a way of somebody asking you or trying to get your attention or your time. And because of a lot of telemarketing and other things that are going on, the people just are much more protective now and much less interested in responding to these kind of things?
I can also respond. I have a little bit different take on that, working from within a system as opposed to outside a system, and I think one that we have learned is that, like the question implied, that recruitment rates are highly variable depending on the population and depending on what's being asked of people. And ideally, what your recruitment rates are likely to be given published information. I think that if you are working from a system and you have some reputation, that as Rebecca was saying, trust between investigators, it's a trust between investigators and subjects that affects recruitment rates. And so I think it's something that has to be really carefully planned for. And another feature that is worth noting is how your recruitment rates is going to affect the generalizability of your findings. And one of the things that we've learned is that if you know you're recruiting from an enumerated population that you think about, if you're given 7-8% recruitment rate, you should try to figure out any you can tell about who in your population and who's not, and how it will affect your generalizability. We recently published a paper in this journal showing that if you recruit for a study that allows you to do an intervention in the home or measurement in the home versus requires a visit to a clinic, you have a very different population. And that population, and we did some data analyses on results from one population versus the other, and showed that not only were the populations different, but odds ratios that you get from whatever factor you're looking at can be quite different, like by several-fold difference in risk factors. So how to recruit is something to pay attention to, not just to meet your recruitment goals, but also to think about how generalizable your research results are going to be.
Okay, I would just, since a lot of us study older folks, that there are often, and this is, I think, reflected in Eric's comments, refusal rates with age. And there are just a couple ways that you can deal with it, one of which Stride is doing by restricting the study to just those years of age or older. You can oversample your smallest cells where things are likely to be the thinnest, not only because of small numbers, but because of increased refusals. But Eric's points about understanding what these are really important.
That was an excellent discussion, and again, I just want to thank our presenters for spending this time with us and sharing all of the insights and experience. This has been a very helpful session. And I think we are out of time. There have been a couple of questions submitted asking if this is being recorded. It is, and when you receive your link at the end of the webinar, you will have information about how to access the recording. You'll also get information about how to fill out a survey, and we would appreciate if you'd take a couple of minutes to do that. It helps us in planning the future webinars. So again, thank you to our presenters. This was a great discussion.
It was great for me to listen to.
Thank you.